Good afternoon and welcome to Battling the Patient Identification Problem, a webinar tweet chat combo from healthsystemcio.com sponsored by NextGate. Just a little housekeeping before we get started. My name is Anthony Guerra and I'm the editor-in-chief of healthsystemcio.com, and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our managing editor and director of social media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can simply view the tweet chat in the media viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel today, so you can type in your questions as they occur to you. Leave the default set to all panelists and send them on in. We'll take them later in the program. And you could download the deck by using the URL on your screen. It's at the bottom of our slides, and it's also been sent out in the chat box. Just so you see how we're going to spend our time today, first we're going to go about 40 minutes with our panel discussion featuring Katherine Lusk, Chief Health Information Management and Exchange Officer with Children's Health System of Texas, Julie Prough, Director of Enterprise Data Quality with UPMC, Laura Young, Executive Director of the healthconnect Alaska, and Gevik Nalbandian, VP of Software Engineering with the NextGate. So, without further ado, let's jump right into the conversation. Katherine, you want to start us off and give us an overview of your organization and role?
Sure, I'll be glad to do that. Children's Health System of Texas is a tertiary care academic medical center that serves as a referral center for the North Texas area. We're 3 hospitals, 50-plus specialty clinics, and we have a primary care outreach. So we are pediatric-focused, academic-based, and research energetic. I'm responsible for all core activities for coding, health information management, patient identity, release of information, those standard things. I'm also responsible for information governance, interoperability, and managing our patient portal. So that's a brief overview.
Very good. Thank you, Katherine. Julie?
Sure. The UPMC is part of the fabric of Pittsburgh here in the regional western Pennsylvania area and beyond. We have approximately 30-plus hospitals, about 600 doctors' offices, home health care. We're an integrated delivery and finance network, roughly 340,000 patient admissions per year, 4.7 million outpatient visits. So a lot of activity running through our Enterprise Master Patient Index. My role here is, again, Enterprise Data Quality Director, and under that title, I have ownership of both the operational and technical components for the Master Person Index, among other things.
Very good. Thank you. Laura?
Hi, I'm Laura Young. I'm the Executive Director for healthconnect Alaska. We were formerly known as Alaska eHealth Network. It's the statewide HIE for Alaska. So we do have a pretty wide reach. The geography of Alaska is far and wide, but we only serve about 800,000 patients statewide. So it's an interesting challenge for us to provide information exchange in such a broad territory for a smaller population than a lot of other states have. That's what we do. I don't know if I'm going to elaborate too much on HIE because I think everyone knows what that is, but we've been around since about 2009, and we do have quite a number of different connections and hospitals connected.
Very good. Thank you, Laura. Gevik?
Hi, yeah, my name is Gevik Nalbandian. I run engineering at NextGate. Glad that we could sponsor this exciting webinar. Looking forward to it. We've been around for 14 years solving the patient identity challenge using our Enterprise Master Patient Index. We have other registries as well. So I run engineering, and recently I now own also the professional services group, and it's exciting to be on this webinar.
Very good. Thank you, Gevik. All right, please define the patient identification problem. What are its causes and effects? Julie?
From our perspective, and I'm sure for just about everybody on the phone, I mean, the causes are really thin data coming in from contributing systems, human error, a lack of standards, You know, a lot of the impacts there, that obviously is going to limit our ability to automatically match these patients up across the various systems, and that really puts pressure on the clinicians as well as the patients in terms of receiving the world-class care that we all want to provide. Obviously, that also has impacts on analytics, population health, et cetera.
Very good. Laura?
Well, I think one of the challenges from a health information exchange perspective is we do ingest data from a variety of different sources, and being able to match up patients accurately across all of those systems is always a challenge. I think the other thing, it depends on, you know, which part of the country you are in. You have some nuances in terms of different types of ethnicities and cultural groups that may have a lot of names that sound similar and the same. In Alaska, we have a lot of different tribal patients, and so they have some very unique names and a lot of names that sound very similar and the same. And so it is very much a challenge in making sure that the patients are matched up properly and that we're presenting a longitudinal patient record that is accurate and it contains the patient's information that only belongs to that patient. So I think that's a challenge you know, the HIEs struggle with to some extent. We do employ a person whose job is to do a lot of manual intervention on our patient matches, and so it's something that we do have to kind of keep a close eye on.
Very good. Katherine?
Well, everyone has really described it very completely, but I'll kind of add a little bit of a different twist on there. Why is it so difficult? Because we lack an agreement on national naming conventions, and we're not using the standards that are available. I'll give you an example. We have the U.S. Postal Service, which is available as an address, and we don't consistently use it, and that's an issue with matching. We also have HL7 PID data that's available for us, and we can use that to capture different information in a standardized method so that we can exchange electronically. But we all have kind of globbed on to fire is sexy, so we're all going to move to sexy. But actually, if we just utilize the standards that are available, like the U.S. Postal Service and HL7 PID data, and get together and agree on national naming conventions, we can start to exchange, and it can be much easier. But this is complex, and it's hard, and change is difficult, and that's why it's so hard to solve.
Very good. You think there's just a lot of human factors and people not willing to make changes and things like that as opposed to technology, Katherine?
No, I think people are willing to make changes, but having them recognize the value of their change is difficult. We have a lot of times technical people that are getting together and they're solving a problem, but they're not, but somehow or other we're missing how important it is to the frontline people when they begin that process, and to have an information governance process where we give feedback. And I'll just give my own organization as just a simple example. We really believe in information governance and managing our patient identity, our master patient index. So we give feedback every single day to everyone who has made a mistake the previous day and issued a duplicate medical record number. So we have a very clean database, but it requires effort up front and engagement of the frontline staff. And those frontline staff, those registrars, understand that they're creating the medical record and how important it is. So I don't think that people don't want to do it. I think that we haven't done a good job nationally of telling them why it's so important.
Great points. Great points. Looking forward to discussing that more. Laura, let's start with you on this question. Please offer specific examples of challenges you've had. You mentioned the issue of the tribal names. Do you want to go deeper into that, or anything else you want to mention?
Well, I mean, I think that's primarily the types of situations that we see. You know, in my history in working in healthcare IT in general, you know, some of the challenges that I've seen over the years are things like babies that are twins that have been born and then their records get commingled. I actually remember a case from a few years back where some twin mothers were in the hospital both having babies at the same time, and their charts got commingled, and we ended up having to kind of go manually sort of separate the charts. And you know, so the challenges of having I think patients that have a lot of very similar demographics because they're either related or they have names that are similar do pose a challenge. From the perspective that we're using algorithm-based matching systems, I think that you know, that's the patient isn't necessarily providing a kind of a golden number for us to use a lot of times, even though we have Social Security numbers and things like that. But we do see a lot less, I don't have a number for you, but we do see a lot less Social Security numbers coming through our system. A lot of, because of, you know, trying to keep identities private and not having, you know, data that can be stolen for financial purposes. A lot less patients are giving out Social Security numbers, or in some cases, provider practices aren't collecting it. They just have a policy against it. So that means that we have less things like that to use as identifiers. And so I think that creates the challenge of making sure that we have some good demographic data in which to make a firm match on a patient, especially when they have names and addresses or other demographics that they're very, very similar to one another.
Right, right. Julie?
I think along the lines of some of the challenges, I think as Katherine mentioned, human error is certainly there, and ours has been a 20-year journey with an EMPI, so working on process improvement and to Katherine's point, getting feedback to the points where the issues may be occurring. So being able to isolate and make reportable information that can go back to the operational areas so that they can, you know, re-educate and take care of as things turn over and educate new folks coming in. But, you know, Katherine will probably tell you and expand on the children population is a difficult population. You know, parents are coming in, they're extremely, you know, upset because of a challenge that is going on with their child, and whether they give the correct information or not is debatable sometimes. So we do find that we have to re-educate frontline staff on trying to better understand and validate the information that's being presented to them. You've got fraud and drug seekers and trying to work through those and better understand downstream with the clinicians and their awareness and trying to get them to feed the information back upstream so that we can do the investigation and eliminate commingled efforts and information. So yeah, I mean, there are a number of different challenges we've had, and by all means we have not solved them all, but we are definitely moving in the right direction by sharing as we are today with others.
Katherine, is the biggest issue at that point of entry where, you know, the registrar is creating that duplicate record? I mean, is the most important point in this battle that initial, you know, mistake, so you don't have to correct it downstream? It's not making sure it didn't happen in the first place?
Yeah, yes and no, that certainly is important, but one of the most important things in the pediatric space is lack of a multiple birth indicator that's available with HL7. The vendor community hasn't made that multiple birth indicator available, so that these 2.5 million children under the age of 18 that are either twins or triplets that have the same address, same parents, same telephone number, and same date of birth, and really very similar names, are all very difficult for the algorithms to sift through and understand that those are really distinct patients. So even if the registrar were to get everything spot on and be absolutely perfect, the fact that there's not this technical ability to capture this discrete element really puts a burden on this very fragile population. So that's where the there is an operational concern and there's a technical concern, and there's some technical capabilities that we all kind of need to embrace and ask our vendor partners to start carrying that flag also.
Very good, very good. All right, Gevik, let's go with you on this question. Why do you think this problem is so difficult to solve?
Can you hear me? Yeah,
I can hear you loud and clear.
Yeah, great. Thanks. Well, I think people have, over time, tried to look for silver bullets, like the single patient ID and other things. And the panels have been talking about, even if we get everything accurately, there's still some issues. I think primarily the issues are, as stated before, education, understanding the value. Also, from a technical perspective, data becomes stale. Manual entry is prone to error. It doesn't matter how well you can train the registrars up front. They have a workflow to follow, and they do the best they can. Not all the systems collect all the data we need. Katherine just said that the lack of multiple birth indicators. We solve that, but if they don't send it to us, we can't help. Right? Recognition of the problem existing in the first place, which leads to resistance to solving it. Right? I mean, I know that people want to solve it. Depends on who you talk to in the institution. The IT folks want to solve it. The business side has a harder time, from our perspective, trying to adopt it because it costs money. So hopefully, as we talk about later on, and then probably the bigger one that I could see is that EMR and EHR vendors don't always want to send all the information out, even if they can. So interoperability becomes an issue, which we'll talk later on.
Very good, very good. All right, next question. How do you measure record matching accuracy? Who leads patient identification remediation? Katherine?
We measure it by number of duplicate medical records created plus the number of overlays divided by the number of registrations or opportunities to make a mistake. Because we think every time you touch a record, you have an opportunity to make a mistake.
Very good, makes sense. Go ahead.
And the HIM department in our organization leads on patient identification remediation. I'm like Laura was talking about, and I'm sure Julie does the very same thing. I have staff dedicated to evaluating our master patient index data integrity on a daily basis, 7 days a week, and we just constantly work it to make sure it's accurate.
Very good. Julie?
I would agree with Katherine in her assessment of ours is dupes and overlays divided by the number of registration opportunities. So in our environment, as Katherine indicated, again, we do have a centralized team that is sitting side by side. Our operational group sits side by side with our IT group. The operational team actually has registration and clinical EHR background, and we work in collaboration with our registration and HIM teams. So it really is a very well-rounded who leads the patient identification remediation. It's centralized, but then we have a data quality steering committee that also helps us push forward our agenda and really help us treat the data as an asset and the patient as the gold record of what we need to strive to get 100% right.
Julie, I'm hugging you from long distance for that data as an asset. Just a big hug coming your way.
All right. I think that's our first virtual hug during a webinar, so we've made history today. Very good. Laura, your thoughts?
Well, my thoughts are that that's actually something that we, as an organization, have a real opportunity around. One of the things that, I was brought into the organization to do is really kind of do an overhaul of our processes and our technology and a lot of the different things that we're doing. So to be fair, we haven't had a real focus on a good measurement of our patient matching. Again, we have some staff that are dedicated to it, but it's not something that we've probably put the appropriate focus on what that measurement is and how we can improve it from a process perspective. We are investing in it from a technology perspective. As I said, we're doing actually kind of a major technology overhaul right now, and the HIE software that we have been using up to this point has been through Orion Health, which has NextGate embedded in it, but it's been a limited sort of version of NextGate for us, and so a lot of the things that we've relied on to be able to run reports and get information and data out, we've had to go back to the vendor for, and that we feel has not it's kind of hamstrung us in some perspectives in terms of being able to do some of that measurement. So we are now contracted directly with NextGate and are moving our MPI from the kind of Orion version over to a version that where we can have a greater management over the EMPI and be able to run reports and be able to get more of that information that we need to be able to improve our processes. So that's something that we could actually use some help around, and so I don't have a good answer for that in terms of what our measurement is today, but ask me again in a year and I'll hopefully have a better answer.
Very good, very good. All right, Gevik, is a national patient identifier the answer to the problem? Is the creation of one even remotely possible?
I don't think so. People have tried it. It's difficult because of many of the things we've said, but adoption, political reasons. But then we have good examples as to why it hasn't worked. The United Kingdom, which we are very vastly used over there, our products, tried the NHS number and has the same issues. And probably not as bad as a social security number because that's overused here in the United States. But they do have a national ID, they have an NHS number, and they do find issues with it. So they can't rely on a single identifier to solve. This is why I said in the beginning, there cannot be a silver bullet. The panel has talked about all these other logistical issues we need to solve. So unless you were born with a barcode on your neck, I don't think we can solve this problem.
Very good. All right, Laura?
I tend to agree. I think a number, you know, we've had Social Security numbers. I think even though those are probably not equivalent to a national patient identifier, they are in other ways. And I think that there's opportunities for fraud and abuse, people using numbers that aren't theirs. There's still data entry issues if it gets entered wrong, if it's a number or something like that. So I do think that it needs to be more than just a identifier. I think there needs to be some additional technology that goes along with it. You know, you have a pretty basic technology available for the most part on your smartphone. You know, I go to log into my bank and I can use my fingerprint, and you know, it identifies me pretty quickly, and it's sort of a biometric type of a thing. So I do sort of see it going that way. Unfortunately, I think we're ways off from getting to a spot where we might be able to rely a little bit more on something that's a little more biometrically based, but I feel like that's going to get us closer. I don't know that I think that would be perfect either, but I think it might work better than sort of a national identifier number that that we're relying on to hopefully be accurate and used properly and entered correctly. I think we would still have some of the same challenges we have today.
Julie?
I agree with Laura and Gevik. I mean, there is no one single bullet. While an NPI or a biometric is another tool in the arsenal, it's really a holistic problem. You're always going to have folks that are going to try to do fraudulently acquire services or steal somebody's identity. So there are different tools that you can use, but it's ultimately going to be a combination of the people, the process, and the technology solving and getting us as close as humanly possible to a true ideal patient identification effort.
Katherine?
Gosh, that's hard for after such great people speaking to even say anything additional on this. And the only thing that I would say is I agree with everything everyone else has said. A national patient identifier would just add an additional cost to the federal government, and maintaining it would be a nightmare, and I'm not sure it would help very much. What I think will help is when we all get together and come up with national naming conventions and a good, strong information governance process where you give feedback to people and you have a culture of patient safety with constant reminders is what's going to help. And technical forcing functions like capture of multiple birth indicators and use of the U.S. Postal Service. And when we as a community ask our vendor community to actually implement those things, like Gevik said, they're ready to accept multiple birth indicators, but all the EMR vendors aren't ready to send them and capture them. So I think that we all have to embrace it and get our vendor community to embrace it as well, because they will do what we ask them to do. It's that we as a community have not asked that question yet.
Well, Katherine, you're helping me segue into the next question. Any more thoughts on the role of the EHR vendors in helping to solve this problem?
Well, I think that the EHR vendors can help by having forcing functions by using the U.S. Postal Service and by providing the ability to capture the use of multiple birth indicators and birth order status, and by capturing both parents' names as social norms change. So I think the EHR vendors can help a lot, but I think that we as a community owe it on ourselves to ask the EHR vendors to do that, because they actually build what we ask them to build. And maybe we haven't been vocal enough to tell them what we would like.
Very good.
I feel like we own it, part of it.
Okay, excellent, excellent. All right. Go ahead,
Anthony, can I add just one quick thing
Please.
on that? So what I have found, and what as we're implementing products, I'm not sure I 100% agree that the HR vendors will do what we ask them without the couple of extra dollars they would want to have us pay them. But the thing is that I don't know what their vested interest is in terms of interoperability, and I might be jumping ahead, but one of the issues I see here is they make it really difficult to adopt the interoperability technologies they have. As an example, they can reach out and ask for information, and they end up charging customers like Katherine, Julie, and Laura a lot of money just to do something simple, something that we already are certified for, all of us at the IHE Connectathon. So I'd like to see them taking a more active role as well. Yes, it is up to us as thought leaders to help them as customers, to tell them what we need, but I feel like they also need to take a bit of an active role.
Julie, Laura, any thoughts on that or no?
This is Julie. I tend to agree that the vendors are going to ask for more funding if we give them additional things to do. But to Katherine's point, I do think the community does need to help them prioritize what as a community is best for the patient and for the clinicians who are serving those patients. So I think being able to stand together is probably going to give us a little bit more leverage, but again, the funding is going to come back. The other thing that I would just say in terms of the vendors, we're always going to have these challenges where we're going to have tasks that have to be attended to. So looking to machine learning and other technology to be embedded as a standard part of some of these is something that I would hope that the vendors are also looking at in the not too distant future, so that they can learn how we're remediating them and help us alleviate that human need for the task remediation.
It's interesting you bring that up. We are heavily invested in using machine learning, so you would be hearing from us very soon on how we're going to use that to reduce the human effort on remediation.
Very good. Very good. All right, next question. Julie, let's stick with you here. What are health systems and HIAs doing today to overcome the patient identification problem?
And again, in our environment, it's really all about the process improvement. So we have integrated, and we've been here for 20 years. So ours is an evolutionary journey. So for us, it is a combination of working with our upfront systems that are sharing the data into our platform, 30 different feeding systems. We're bringing in outside data, We have over 24 million records that equate to about 8.7 million unique persons. So there's a lot of data there and a lot of rich mining that can be done. So again, it's really upstream and the collaboration with our access management revenue cycle folks in terms of ensuring that, to Katherine's point, we give them as much feedback so that they can give us as much as they can in terms of high-quality data on the inbound feed. But it's also reaching out to the others that we ingest and giving feedback to them. So whether it's our health plan and it's a flat file coming in, how do we profile the data, give them feedback so that they're aware and can make their efforts better. That's kind of one of our focus areas, right, that we've been leveraging for the past 20 years.
Very good. Katherine?
Well, I have something kind of exciting to tell you. We do exactly what Julie is doing internally, but what we started to do externally is I lead a Texas EPIC collaborative on interoperability, where all of the EPIC customers in Texas, all 24 of us, work together to improve our interoperability and to really exchange records more freely. So one of the things that we did in the summer of 2017, we got together and we adopted the Children's Hospital Association patient naming conventions, and we all agreed to abide by them. Now, mind you, we're not monitoring one another or anything like that. It's a gentleman's agreement. But the minute that we adopted those standards, our interoperability improved, and we began exchanging more and more records. So I think that that's what all of us need to do, is we need to kind of get together and start garnering that sort of support internally as a local group, and then regional, and expand it nationally. And then that way that we can come up with a de facto patient naming convention that can help interoperability.
Very good. Laura?
Well, I think I've talked a little bit about what we're kind of working on in terms of, focusing on a more, I guess, robust version of our EMPI. One of the things that that we have an opportunity around, and there's some struggles with this too. Alaska's unique because in Alaska, folks can apply for the permanent fund and get a dividend. It's something, it has to do with oil futures and that sort of thing, but everybody who's a resident can apply for that. And so they do go through the state of Alaska. There's an application process. They do give some demographics, and it's actually pretty comprehensive because they want to make sure that you're truly a resident, you've been here for a while. But in that process, they actually are given an identifier. That's pretty accurate because the state validates their demographics. So that's an opportunity that we may be able to bump up against that data set to do some patient matching. I think it's a unique opportunity that a lot of states may not have in terms of people who are volunteering to give their demographics in order to get something in return. And so they obviously would like to get their checks sent to the right address and things like that. So it gives us a pretty good accuracy in terms of making sure that, we're getting their demographics appropriately, and then we could match it up against the data sources that we have. So we have some kind of unique opportunities there, and I have kind of wondered if there isn't opportunities like that from a national perspective where the demographics actually come from the individuals themselves versus us relying on them being entered. Not that we wouldn't still enter them at the point of care, but that the validation has a bit of a reward attached to it, and so therefore people would validate themselves and give better information about themselves in order to receive something. So that's an interesting concept that I think is presented as a unique opportunity in Alaska that I think can be very useful in terms of improving our patient matching.
Very good. Very good. All right, Katherine, what's the role of an MPI cleanup, especially for ongoing maintenance?
I think that an MPI cleanup is something it's important and should go on forever. It is something that you should embrace and work every day, all day. And as far as a cleanup, the first cleanup, once you pay for one and once you do it, you never want to go through it again. So it's expensive, and so you just have to be invested in keeping it clean.
All right, very good. Julie?
I don't know that I could describe it any better than Katherine did.
Okay, so you definitely, it's like going to the dentist. Is it not very pleasant?
Well, it's definitely necessary, and you know it does garner information that you can share back with the front registration personnel and others. But ultimately, it can be painful. It can be costly. So if you do it once and you don't continue to do it, as I think Gevik said earlier, that data is going to go sour because it's going to get stale, it's going to get old, and nobody's attending to the quality.
Very good. Okay, Julie, stick with you. Do EHR EMR systems typically accept and perform merge transactions, or do merges have to happen manually?
For what we've encountered, for the most part, most of the EHRs are indeed accepting the merge transactions coming out of our EMPI. We centralize and broadcast from the EMPI those merges. We do find as we continue our integration pathway that some of the smaller facilities may not necessarily have that instantiated because they don't have a great number of contributing points of entry. So it's not really something that we find in the smaller platforms or smaller facilities that we integrate with, but most of the large EHRs do indeed have that capability and do that.
Gevik, any thoughts on this?
So we have, because we work with quite a large number of customers, we don't have the same experience. Quite a few that we have, and I don't want to come up with a percentage because each scenario is different, but quite a few we deal with don't, and so it has to happen manually, or a combination of that and the lack of proper data governance. Those merges have to happen within the local system. So we see it all. So. Yeah, I guess I would partially agree, but we've seen enough to say that it's not all.
Very good. Katherine, any thoughts there?
No, I'm just going to have to go on Gevik. He'll have a much broader view than I do on this. Our EMR system does accept the electronic merges, and we actually rely on it quite heavily when we purchase other clinics and things like that. So, but Gevik would have a broader view than say I would, or maybe Julie would have, or Laura would have a broader view.
Okay, Laura, do you want to offer any thoughts there?
Well, I think that there's an opportunity there. I've seen that most EMRs do accept the merges as well. From an HIE perspective, we don't necessarily always send that information back downstream, although we do have some providers that have actually asked for that, where they want us to be, from a statewide perspective, offer up the master patient identifier and do some of the matching on our side and then send them back information. So it sort of really depends on what the organizations we work with are wanting to get back from us in terms of whether they will even operate on that. So a lot of times what happens is we're doing patient matching really on our side, our patient merges, that may not end up happening again downstream. We have some large hospital systems in our area, and we've run into some interesting challenges where at one point we had a registrar that I guess didn't know how to create a new record, and so she was pulling up, she'd search for somebody and then just type over the record and put in new demographics. And so, as you can imagine, that was something we were seeing on our side, but in that type of an instance, it's an education opportunity for us. So we would call that facility, let them know what we're seeing, and then the cleanup really has to happen on their side. So from an HIE perspective, we do see ourselves as a convener to be able to sort of educate and help organizations where we are seeing that they may have some challenges. But I wouldn't say that it's always an automatic type of a situation.
All right, let's go to my favorite part of these webinars, the Ask a Co-Panelist section. And for the sake of time, since we have 4 panelists today, just pose it to one of your fellow panelists. So Laura, let's start with you. Do you have a question for one of your fellow panelists?
Well, we've talked a lot about different methods for doing identification. I'd be really interested in hearing Gevik's take on, some maybe things that we could implement to, from a technology perspective, to improve patient matching. If we've algorithms or it's biometrics or things like that, that maybe we could focus on.
Okay, that's a good one. So I guess we have some of the answers discussed across the panelists. Standardization is important. If we can have information come to us in a consistent way, then that increases accuracy. I don't know how much control you have over your own algorithms. If you do, then yes, there are algorithms for improving. So for instance, we moved to using triple metaphone that compensates for 98% of human errors. It used to be double metaphone, and in some old systems they use SoundX. But even that has issues, and this is why I was saying that we are heavily investing in machine learning. And in some cases, using some external data sometimes helps, but that has its own issues where you are by law limited to getting information for citizens over age of 16 or 13, whatever the law is. So I think it probably requires additional discussion per environment what can be done, but standardization, interoperability, tuning of the algorithms, those all help.
Very good. Very good. Julie, a question for one of your co-panelists.
Sure. I think from Laura's perspective, I'd reach out and ask what kind of governance structure they have in place for the HIE up in Alaska.
Can you restate the question?
Sure. Your governance strategy for coordinating across all of your contributing sources to the HIE. Do you engage just the IT? Do you engage the IT in the business?
Yeah, this is one of the areas that I think we have opportunity for the process improvement. Our governance process, I mean, when we engage a new participant, we do have a pretty involved process in terms of a participation agreement, and then involving the technical staff from an implementation perspective. But from a data governance perspective, I think there's a lot of work we could do there. And having worked with other HIEs, I think that the data governance process is a lot stronger than what we have currently at our organization. So I think that's something that we could use a lot more work on. I think it is important. We want our participants to be partners in that data governance and making sure that what they're giving us is clean. I think from an HIE perspective, again, as that sort of neutral convener, it's another opportunity for us, again, as an educator, to say, hey, we're seeing some data that is coming in and it's not very clean, and here's some opportunities where we might be able to help you clean up your data, or maybe make sure that the way that you're sending the data or collecting the data in some cases could be improved. We do a workflow analysis with organizations, and sometimes we do identify opportunities in their own processes, whether it's how they enter data into their EHR systems that could be improved, and so we'll make recommendations around that I think can be very helpful in terms of what we end up ultimately receiving downstream. And the other thing that I see is that there is no there's no standard way that organizations are using their EMRs. You know, you could have the same EMR across 3 or 4 different organizations, and they all use it differently. Some may be using the discrete data elements the way that, you know, we hope that they will use them, and then others maybe aren't using the discrete data elements and doing a lot more freehand text type stuff that, of course, isn't as usable when it comes to patient matching and doing other things with that data. So those are opportunities, again, from an education perspective to help our participants better utilize their electronic health records and then make them more robust all the way around for their own purposes and then from an HIE perspective as well.
Great. Makes it, thank you.
Very good. Katherine, question for a fellow panelist?
Certainly, and this is selfish, and I'm going to ask Laura. Laura, we're rewriting the Children's Hospital Association's patient naming convention, and the one place that we're kind of stumbling in because we don't have very much experience is tribal naming conventions. So can you give us some advice on that?
Wow, yeah, that's an interesting challenge, and I think, and when you're saying naming conventions, are you meaning from a patient name perspective?
Yes. Exactly. Katherine first name, Lusk is last name, and I understand.
Right.
Yeah. So how does
I think that, you know, in Alaska especially, we're really challenged by this because we have a multitude of different tribes, and they all speak different languages, and they have their own naming conventions. So from our perspective, this has been a real difficult thing to track on in terms of as you said, whether maybe they use a last name instead of a first name, and, you know, their common family name is really their first name, or things like that. I think that those are one of those things that requires partnerships with your tribal organizations. We do have the benefit in Alaska. We have a large tribal consortium. It's very organized compared to other states that I've seen. And so the tribes from a healthcare perspective have banded together, most of them. There's some outliers that have not kind of joined that consortium. So I think for us, what we need to do, and we haven't, again, focused heavily on this, is really partner with that tribal consortium to get some education from them on, you know, the ins and outs of how those different types of nuances are from a patient names perspective. And so I think, unfortunately, I don't think it's going to be an easy thing to solve. I don't think a lot of other states, I haven't, not to my knowledge, have such an organized sort of one place you can go to talk to all of the tribes. So I think that you may have to really strike up some partnerships with those tribes and you know, be educated by them. And then I think it becomes a bit of a how do you map that on the back end, the technical side, having some mapping rules and things like that that you can do. Whether it's within the MPI or maybe it's something that you're doing in your integration engine, things like that, where you can do maybe some conversion and or mapping to sort of make sure you're normalizing what you see and what you take in.
Very good. All right, Gevik, a question for a co-panelist.
I'm not sure if they're going to like my question. So this past HIMSS and other times with local HIMSS chapters, when I go to, I try to find a CIO and start talking to them about the patient identity challenge. And to my surprise, and I don't want to mention names, it's definitely not anybody on this panel, who said, no, we don't have a problem, or that's such a low priority for us. So I'd like to ask the panel, why do they believe that CIOs don't want to admit or know that they have a problem on their hand? Some CIOs.
Katherine, you want to start us off?
I will. And Gevik, I think that our CIO here absolutely understands the problems associated with patient naming conventions and connecting and exchanging patient records longitudinally. But if you were to ask her or to ask me, do we have a problem internally, No, we don't have a problem internally because we have really embraced information governance and that feedback loop in training our registration staff. So I think that there may be organizations that do have problems, but not all do have. So I guess that's my answer to the question.
Okay, sounds good.
All right. All right, we have an audience question I want to get to. And the question is this. Let's go with Julie on this. Do the same staffs manage patient records across acute, ambulatory, and other clinical systems?
So in our environment, we actually have, as I said, centralized data quality, but they reach out to, as appropriate, any of the different quadrants that are needed. So if it is our key ambulatory and clinical systems, they are taking care of it, but if it's a flat file we're getting in from our health plan, for example, or it's something coming in from state immunization, they will reach out to those areas and coordinate. So it's kind of a split, centralized versus some level of collaboration with others.
Catherine, any thoughts on that question?
We do it the same way that Laura does it. It is Julie does it. It is actually centralized and everything goes through the HIM department, but the registrars at each and every location some report directly to the ambulatory owner and some report to a centralized registration service. So it's very similar.
All right, very good. I think we're going to wrap it there. We're about out of time today. What a great conversation, a lot of good information, and a lot of interesting thoughts on this topic. When you close out of your WebEx window, you're going to be taken to a post-event survey. If you could take a moment to answer that, we'd appreciate it. Regarding continuing education, attending our events gets you 1 CEU towards the CHIME CHCIO certification program, so let CHIME know you were here, and if you've asked us to do so, we will. You'll receive an email when our archive recording of this event has been posted to our YouTube channel. If you'd like us to produce a webinar on the topic of your choice, you can reach out to Nancy Wilcox on our team. And you can go to our website to view our upcoming schedule of events, which is quite robust. So with that, I want to thank our panel, Katherine Lusk, Julie Prough, Laura Young, and Gevik Nalbandian. I want to thank NextGate very much for making this important conversation happen, and I want to thank you, our attendees, for continuing to join our webinars. So with that, everybody have a wonderful day. Thank you.